Well, welcome to the Severe Asthma and Health Disparities in Hispanic Communities webinar. Thank you for joining us today for the National Hispanic Medical Association's webcast. It is supported by the company Amgen. I'm Dr. Roberto Johansson. I'm an executive board member serving as treasurer for the National Hispanic Medical Association. In case you don't know, the NMHA is a Hispanic Medical Association. It's a nonprofit. We represent the interest of 50,000 licensed Hispanic physicians, and more importantly, we represent the interest of our predominantly Hispanic patients. Our mission is to empower Hispanic physicians to lead efforts to improve the health of Hispanics and other underserved populations. In collaboration with the Hispanic state, medical societies, residents, medical students, and other public and private sector partners. I am so thrilled to have our guest speaker today, Dr. Juan Celedon. He's the Division Director of Pulmonology, a Professor of Pediatrics and Professor of Medicine and Epidemiology and Human Genetics at the University of Pittsburgh. Dr. Celedon is a distinguished physician and scientist and mentor who has co-authored over 360 publications. He's mainly on genomics and epidemiology of airway disease and focusing on Hispanics and other minority groups. In appreciation of his scientific contributions, he was elected to the American Society for Clinical Investigation and the Association of American Physicians, while also receiving the Recognition Award for Scientific Accomplishments, the Lifetime Achievement Award for Innovations in Health Equity, and the John Peters Award from the American Thoracic Society. In May 2020, he became the first Latino to serve as the ATS president since the society was founded in 1905. Thank you, Dr. Celedon, for sharing your time today. I do have some housekeeping issues. Will the next slide come up, please? All participants, please mute your microphones so that we don't get the resounding. Please feel free to use the raised hand feature or to be unmuted for a question, or type your question in the Q&A for the panelists to address during our Q&A session. This webcast is being recorded, and it will be housed on the nmhamd.org website or the NMHA YouTube channel. And the recording and the slides will be sent out to all participants 1 week after the event. And again, thank you so much for being here. And again, thank you to Amgen, our sponsors. Dr. Celedon, again, thank you for being here.
Thanks, Dr. Johansson, for that kind introduction. I'm going to share my screen, and we should be all set. So good afternoon, everybody. It's truly a pleasure to be here with you to talk about asthma, particularly severe asthma. And Hispanics, I've been asked to emphasize asthma in Hispanic adults, and so that's what I would do. I would mention children once in a while because of our studies, but mostly it would be about Hispanic adults. I have received research materials, inhaled steroids from Merck, to provide medications free of cost to participants in NIH-funded study. It's completely unrelated to this presentation. I'm not going to discuss any unapproved commercial products. So as pretty much I think everybody in the audience know, the Hispanic population has grown substantially. So right now it's close to 19% of the US population in 2022, expected to grow up to 25%. And it's a diverse population composed of different subgroups. Asthma is the most common chronic disease of childhood, affecting 6 million children. It also affects 19 million adults in the US. And around the world, it's estimated over 330 million people have asthma. It poses enormous cost to our healthcare system. A few years back, about 7 years ago, it was estimated that asthma posed $81 billion per year to our healthcare system. Asthma is a disease that is characterized by airway inflammation, airway remodeling, hyperreactivity to non-specific stimuli, such as cold air, allergens, and airflow obstruction that is often but not always reversible. These are data from a few years back for children and adults in the US. And the point is to tell you that asthma is not an equal opportunity disease. Asthma disproportionately affects the economically disadvantaged in this country. Now, when you look at asthma by racial or ethnic groups, it appears as if Blacks have the most asthma. And if you look at Hispanics as a whole, they have less asthma than either Blacks or whites. But this is a fallacy. This is a fallacy that has to do with the fact that Hispanics comprise several subgroups, including the two largest, Mexicans and Puerto Ricans. Once you decompose Hispanics into subgroups, Puerto Ricans have actually the highest prevalence, morbidity, and mortality from asthma. This is true in children and adults of all major ethnic groups in this country, whereas Mexicans have the lowest burden of asthma. This phenomenon is known as the Hispanic Paradox. It encompasses not only asthma, but other conditions such as chronic obstructive pulmonary disease, COPD, and prematurity. Puerto Rico is the US state or territory where the most preemies are delivered per year, whereas Mexican women deliver the fewest preemies. You do not see this for conditions such as obesity and diabetes, in which both groups are heavily affected. Now, why do we see these disparities? These are multifactorial, with factors at the individual and community level. All of these, except genetics, to date, are modifiable or potentially modifiable. They include poverty and all that's correlated with it, indoor and outdoor pollutants, diet, exposure to violence and chronic stress, access to care, literacy and cultural beliefs at the individual level. And then at the community level, you have some of the same, but now you can add things like housing conditions, outdoor pollutants, again, exposure to violence at the community level. In a given patient, many of these factors may be operating or coexisting at the same time. In fact, that's more often the case than the exception. So going back to this again, there is this fallacy if you look at Hispanics as a whole for asthma. In fact, now I'm going to show you some data for current physician-diagnosed asthma or active asthma in US Hispanics. These are data from a very large study, 16,000 Hispanic adults living in 4 cities, Chicago, New York, San Diego, and Miami. And in this study, after adjusting for age, sex, DH, and immigration, time in the US and other covariates, Puerto Ricans had an adjusted prevalence of 15.3%, by far the highest, whereas Mexicans had almost 5-fold lower prevalence at 3.4%. And then you have other subgroups in the middle, such as Cubans at 8.6% and Dominicans at 6.7%. Now, if you look at now healthcare utilization or morbidity from asthma, you see some of the same things. So in here, we are comparing Caribbean Hispanics, predominantly Puerto Ricans, to other Hispanics in this study from PCORI. So this is a study by my colleague and friend, Juan Carlos Cardet. And here you see that Caribbean Hispanics, Puerto Ricans, had 2-fold higher odds of hospitalizations, need for systemic steroids, visits to urgent care or the emergency department. This is very recent data. So here you have it. This being shown over and over again, that Puerto Ricans have very high burden and Mexican Americans relatively low burden. And this is partly why. So as many of you know, if you go to Latin America, if you go to Colombia, where I'm from, and you use this term Hispanics or Latinx, they really won't know what you're talking about. This is a term designed by the US Census. As such, it includes individuals whose ancestry can be traced back to lands that were under Spanish control. Those individuals who can trace their ancestry to large parts of the US, Central and South America, some Caribbean islands, including the Dominican Republic and Puerto Rico, and Spain, are considered Hispanic. Hispanic or Latin or Latinx or Latino is an ethnicity and not a race. Hispanics can be of any race. Most are racially admixed, with variable proportions of European, Native American, and African, but we can have Asian, Hispanic. So this slide serves to illustrate this. You have Rigoberta Menchú, a Mayan from Guatemala, winner of the Nobel Peace Prize. You have two players of the Red Sox. One is Mike Lowell, a Puerto Rican of Cuban descent. And then David Papi Ortiz, who was recently inducted into the Hall of Fame, who's Afro-Dominican. You have Alberto Fujimori, who was born in Peru. His parents are Japanese. And finally, my comadre Shakira, who's from my hometown of Barranquilla, Colombia, who's half Lebanese, half Colombian. If these people were answering the questions in the US Census, they would all have to check the box Hispanic. So if you mix all of these people together, of course, in biomedical research, more often than not, you may get biased results, and that's the case for asthma. So why do we see these paradoxical findings for Puerto Ricans and Mexicans? It's multifactorial again. There are some risk factors that are common to both subgroups. So things like obesity, poor diet, poor dietary habits, poverty, they are disproportionately represented among the poor, lack to a good health insurance, limited health literacy, and air pollutants. However, they are divergent with regard to other risk factors. Puerto Ricans have a greater degree of African ancestry. And African ancestry, unfortunately, because of the history of this nation in Latin America, is correlated with the structural and social determinants of health, including poverty, racial discrimination, redlining, and others. They also have higher levels of chronic stress than Mexicans, and in general, lower levels of community support, shown in various studies. Puerto Ricans smoke far more heavily than Mexicans, particularly among women, and they have also been shown to have lower response to bronchodilators such as albuterol. In contrast, Mexicans have greater Native American ancestry, which has been correlated with lower risk of asthma. We're still trying to understand why. And in general, they smoke less. Let's briefly talk about racial ancestry. So these are data from a study of 678 Puerto Rican children. They were ages 6 to 14. They are represented by the red dots. Okay. Here you have Native American ancestry. Here you have European ancestry, and the yellow represents European ancestry. Some of these kids are, say, purely European or purely African. They have relatively low Native American ancestry on average. It's less than 10%, but they're in between with, on average, 25% African ancestry. And in this study we published a few years back, consistent with what has been reported in African Americans who are racially admixed, the greater the degree of African ancestry measured with genetic markers, the lower the lung function. This is after accounting for several covariates. One has to be very careful about how to interpret this data. I'll get to back this later, because again, African ancestry is a marker of many environmental and behavioral factors, but nonetheless, it's interesting. In contrast, I'm going to show you data from Costa Rica and Central America. So now I'm going to show you data from adolescents and adults living in Costa Rica. Here, the green dots are Costa Rican adolescents and adults in a prior study we published. They are the green dots. African is the black dots, Native American, the red dots, European, the yellow, the blue dots. Costa Ricans have very little African ancestry, particularly those from the Central Valley of Costa Rica. They are predominantly European and Native American. And in this population, Native American ancestry is positively associated with lung function. These results for global ancestries have been replicated by other groups. So this is my colleague Esteban Burchard, in collaboration with a group at USC, did a meta-analysis. These are data from children, showing that again, in these racially admixed Hispanics, Native American ancestry is associated with lower risk of asthma, whereas African ancestry is associated with higher risk of asthma. We don't think by any means that this is related to mutations that are more common in people of African ancestry, but rather that this is a marker of other factors that we have to dissect and decompose. And our group and others are interested in looking at things that are correlated with African ancestry, including poverty, racial discrimination, redlining, environmental risk factors, etc. So I'm going to briefly touch on genomics and epigenetics. And these are data. Interestingly enough, I told you that Puerto Ricans have the most asthma. However, many years went by between the first genome-wide association study of GWAS of asthma in whites and this study that we did in Puerto Ricans. So we gathered data from 4 different studies. These are children and adults. They are all Puerto Rican descent. And most of these studies were case control studies, Pierre Gold, Gala 1, Gala 2. So they had about half or over half asthmatics. The other one was sort of an unselected population, the study of Latinos, Latino adults. And they were conducted in multiple sites in the US and Puerto Rico. And what we found in this study, this is what's called a Manhattan plot. So on the X or horizontal axis, you have the chromosomes. On the y-axis, you have a statistical significance. The red line indicates genome-wide statistical significance. And in these 5,000 plus Puerto Ricans, there was one locus on chromosome 17 that was highly associated with asthma. This is by far the most highly replicated susceptibility asthma locus in all races and ethnicities. And it was quite interesting that there was such a strong signal in these Puerto Ricans. We were also able to replicate some prior findings in Europeans for some genes like the thymic stromal lymphopoietin, but not for others. To us, what was very interesting is that this locus on chromosome 17 is associated with the function and integrity of the airway epithelial barrier, right? Suggesting that perhaps there are some environmental factors that these children and adults are exposed to that may be altering their airway epithelium and leading to asthma or worse asthma. In fact, this is right now if you will, the hottest area of interest in asthma, into how asthma is caused and so forth. So this is a diagram or figure from the Journal of Allergy and Clinical Immunology from 5 years ago. And this hypothesis of the defective airway epithelium basically says, well, there are some people who have a defective barrier by virtue of heredity or other things that we're trying to understand, their microbiome. They are exposed to things like viruses, pollutants, allergens, and these injurious agents penetrate beyond this barrier, interact with dendritic cells, and this leads to autoimmune responses, to exaggerated Th2 or atopic immune responses, or exaggerated Th17 neutrophilic immune responses, and then a child or an adult gets asthma or their asthma gets worse. Because of this, over the last few years, we've been doing studies of airway epithelium in Puerto Ricans. And we take nasal samples, both in children and adults. And you're going to say, why nasal samples? The reason is that we and others have shown that something called DNA methylation and also gene expression in nasal epithelium are highly correlated with those in bronchial epithelium. So this is a non-invasive way of assessing airway epithelial expression. You don't need a bronchoscopy, which would be, risky, would be expensive. You can do this in hundreds of patients, and we have been doing so. Why are we so interested in this? Because this is a way we can look at how the environment influences the function of genes beyond your DNA sequence. And one of the mechanisms is methylation. You can, by virtue of environmental exposures, methyl marks are added to your DNA. The more methylated a site is, the lower, in general, gene expression. Conversely, if you remove these DNA methyl marks, then gene expression increases. So we published this paper now 3 years ago in the Lancet Respiratory Medicine. It was the first genome-wide study of DNA methylation in nasal epithelium in relationship to atopic allergy and allergic asthma in youth. So this included people up to age 20. And these are the characteristics of the cohort. The first cohort was from Puerto Rico. There were 483 participants in total. And then we had data from two other cohorts. The cohort in the middle is by Yang et al., and that is 72 African-American adolescents living in Denver. 36 with asthma, 36 without, much smaller than our cohort. The third cohort is a cohort of Dutch adolescents. They were 16 years old, living in Groningen, in Holland, and whom we also had some data. They had fewer asthmatics in that cohort, but nonetheless, they had data on DNA methylation in nasal epithelium. And what we found was striking. So here you have the same Manhattan plot that I showed you before. But now, instead of looking at polymorphisms in genes, we're looking at methyl marks across the genome. Here you have your statistical significance. Red line is genome-wide significance. And there were thousands of these methyl marks that were associated with asthma in this Puerto Rican population. And most of these methyl marks were functional, meaning affect expression. The more methylation, the less expression, the less methylation, the more expression. But to us, what was most striking is, we asked the question, can we use a panel of these methylation markers to differentiate participants with asthma from those who have no asthma? And using 3 different methods, it's called machine learning, we showed that we had 88% accuracy. To put this into context, if you use questions from validated questionnaires, your accuracy will be about 65%. If you use genetic markers, the ones we have now, you're in between 63 and 66%. So this is far more promising. But to us, what was really encouraging is that when we replicated this in 2 populations living in different parts of the world, people of different race and ethnicity, the accuracy was still very good. 82% in African-American, small cohort, 87% in Dutch adolescents. So of course, this opens a new avenue for research, because right now we're doing a study of nasal epithelium in Latino adults. And our goal is to see where we can develop nasal markers that predict response to common treatments and prognosis. So again, we're very excited. These new studies will be longitudinal. The ones that I show you were cross-sectional snapshots. So I'm going to completely switch gears from genetics, genomics, to now psychosocial stressors, mental health, and asthma, which is an area that our group has been very interested in. So why are we interested in this? Well, I already told you about the high burden of asthma in Puerto Ricans. But also, Puerto Ricans happen to be exposed to high levels of violence in their communities where they live in the island of Puerto Rico. And you probably by this time all know they just were hit by Hurricane Fiona, or a major catastrophe. And also in the mainland where they live in the Bronx, Lawrence, Massachusetts, etc. They are also particularly susceptible to the detrimental effects of catastrophic events or violence. After the Vietnam War, the veterans that reported the most symptoms of post-traumatic stress disorders were Puerto Ricans. After the events of 9/11, when you look at the different racial or ethnic groups in New York, Puerto Rican adults reported the most PTSD symptoms. And we and others have linked violence and stress to asthma. So how could this work? So you have an individual, a patient who's exposed to violence at the individual level, pre or postnatally, as adults, as children, in their family, in their community through crime, or through war. I mentioned the Vietnam War, can go to the Gulf War, etc., or natural disasters like hurricanes, like we're experiencing right now. These individuals are going to be chronically stressed. I don't think anybody in 2022 would argue that if an individual with asthma, an adult with asthma, gets a chronic stress, their asthma is going to get worse. They will get more severe exacerbations, hospitalizations, ED visits. They will require steroids more often. There is still some controversy, although the body of evidence is growing every day, that stress from violence can lead to new onset asthma. I'm going to show you some of that data. So this paper was with Drs. John Brem and Seema Randrabnan from our group. It's about 4 or 5 years of work. We knew going in that Puerto Ricans have lower response to short-acting bronchodilators, such as albuterol, than members of other ethnic groups, like Mexicans or whites. Initially, this was attributed to mutations in the gene for the receptor for albuterol, which is the beta-2 adrenergic receptor gene, or ADRB2. However, as I was writing a grant, I ran into work by Greg Miller, who's now a collaborator and colleague from Northwestern, who wrote this paper showing that if you look at white blood cells of subjects with asthma, and you divide them by their level of stress, acute and chronic, those who were chronically stressed have lower expression of the gene for this receptor, for the beta-2 adrenergic receptor. The worst effects are for those who are acutely and chronically stressed. So the logical question then is, could stress partly explain why Puerto Ricans have lower response to albuterol? In fact, that's what we found. So on the top, there are 234 youth with asthma from Puerto Rico, and we measured the response to bronchodilator. In this age group, 8% would be significant for a research study. So we find an effect of almost 4%, which is 50% of a clinically significant response. I said, that's interesting. We went to a second study, the Rhode Island Puerto Rico Asthma Center, which includes Puerto Ricans, Dominicans, and whites in Rhode Island. They had data on anxiety and panic disorder. And the participants who had anxiety and panic disorder had lower response to bronchodilators as well. Now, you could think, well, that makes a lot of sense. They are stressed, and therefore they are not using their medications. They are not using their controllers. They are not using their inhaled steroids. That's why you're seeing this. So to try to address that, we found a group of 87 adolescents from a national group. This is a racial and ethnically diverse sample. These are people who had never been diagnosed with asthma. There were no medications for asthma. They had no asthma symptoms. However, in spirometry, they had a reduced ratio of FEV1 to FVC. And in those people, high levels of anxiety were also associated with lower response to bronchodilator. So next thing we did was before this work, we have shown that there is a gene that has been implicated in PTSD in adults and anxiety in kids. And we had data on this gene, and we gathered data from 2,700 children and adults in different parts of the world, again, racially and ethnically diverse sample, and showed that there is a polymorphism in this gene that is associated with lower response to bronchodilator. Then, in collaboration with Dr. Kerry Ressler, who's a psychiatrist, Kerry had data on functional MRIs of the brain. That's what I'm showing you, in heavily traumatized Black women living in Atlanta, inner city Atlanta. These are adults. And in this adult woman, those who had the risk allele for lower response to bronchodilator had increased connectivity of the amygdala and the insula in these functional MRIs of the brain. And that's a radiologic biomarker of anxiety in adults. So putting all of this data together, our findings suggest that subjects with asthma who are chronically stressed may have persistent and increased secretion of catecholamines and downregulation of their beta-2 adrenergic receptor, and that such effects are more marked in people who are genetically susceptible. We are not saying this is the only gene. In fact, I'll show you data suggesting that other genes may be involved, but nonetheless, this is quite interesting. So stress has direct effects and indirect effects. So individuals, your patients who are chronically stressed may smoke more, may be more likely to have an unhealthy diet and become overweight or obese, which is a risk factor for asthma. They may not use their medications as often as they should. And there are also direct effects. So I show you data to suggest that there are effects on genetics. I didn't show you this, but also on epigenetics, DNA methylation. This could lead to chronic activation of the hypothalamic pituitary axis, abnormal immune responses. You have downregulation of beta-2 adrenergic receptors. We also think that they may have downregulation of the glucocorticoid receptors, less response to steroids, and therefore their asthma is worse. So what about depression, another mental illness? So this is a study we did with my colleague, Larissa Canino, who's a psychologist in the island of Puerto Rico, probably the best NIH-funded investigator in the island at this time. And we had data on 3,049 Puerto Rican adults. They were 18 to 64 years living in Puerto Rico. And in these adults, lifetime exposure to violence, which we assess with a quantitative validated scale, and suicidal ideations were both independently and significantly associated with asthma. This was after accounting for other risk factors like obesity, smoking, and other covariates. We also look at another condition called asthma COPD overlap. So when I started talk, I told you that some patients don't have complete reversibility. So this is the patient that you see that has had asthma all their lives, they never smoke. You give them a test of bronchial response, they don't respond. You give them steroids, they don't reverse. So you can call them different things, severe asthma, asthma COPD overlap. But in this cohort, exposure to violent and suicidal ideations, severe depression were also associated with asthma COPD overlap. More recently, we have been looking at child maltreatment, childhood abuse, and asthma in adults. So long-term effects of childhood abuse on asthma in adulthood. We and others have linked child maltreatment to mental illness in adults. Major depressive disorder, or MDD, generalized anxiety disorder. My colleague, Larissa Canina, has shown this, in fact, among adults in Puerto Rico. In turn, major depressive disorder, anxiety disorder have been associated with asthma in adults in large prospective studies, not only of Puerto Ricans, but also in other racial or ethnic groups. So a question that we had was, could an association between child maltreatment and asthma in adults be partly explained or mediated by depression or anxiety? So to study this, these are not Hispanics, these are 121,000 British adults in the UK Biobank. And this is what we found. In these British adults, those who reported any child maltreatment had 22% excess odds of asthma. They're adjusting for multiple covariates. And we also found a dose-response relationship. The more types of child maltreatment they reported, the higher the risk of asthma. But then we did something called a mediation analysis. So in essence, you are interested in the relationship between child maltreatment and asthma in these adults. And the question is this partly mediated by depression or anxiety? In fact, both of them, depression and anxiety, were independently mediators of this relationship. But if you look at either and or, together they explain about 38.2% of this relationship. So why is this important? Because if you're looking at an adult with asthma, right, first of all, you should always look for coexistent depression and anxiety. I highly recommend that. And in fact, most, I know that the ABIM, for example, the ACP recommend that there is some short screen for depression in all adults, right, regardless of asthma. If they are depressed, they should be treated, right? Asthma can lead to depression. Depression could lead to asthma, both ways. And we don't know yet the impact of that in asthma, but it's advisable. And also, this should be, particularly in those who have reported child maltreatment, this is even more important. So what about diet? This is Dr. Yu Han in our group who leads this work. So briefly, these are data from the National Health and Nutrition Examination Survey that includes Hispanics. It's enriched for Mexicans. And what you see in this slide are data for children and adults. So on top are children, on the bottom are adults. And we had data on something called fractional exhaled nitric oxide, or FeNO, that you can measure in patients with asthma. In general, those who have an increased level of FeNO, in this case, at least 20 parts per billion in kids, 25 parts per billion in adults, are thought to have more eosinophilic airway inflammation or type 2 or atopic asthma, to make this simple. And what we saw was that in children, those who had a poorer diet, and this is measured with something called the dietary inflammatory index. It's a measure of pro-inflammatory diet. In general, more saturated fats, dairies, sweets, etc. They had a greater risk of asthma with each quartile that went up in this index. And we saw a similar thing, in the adults, with the effects being more marked in those who had eosinophilic airway inflammation, probably T2 high asthma. Then we look at diet and asthma in Hispanic adults who participate in this largest study, which I already mentioned, the Hispanic Community Health Study - Study of Latinos. 16,000 adults living in 4 different cities in the US in whom we had dietary information. So on top is this dietary inflammatory index, or DII. And you have quartiles. The higher the quartile, the poorer their diet. And in these Hispanic adults, poor diet was associated with higher odds of current active physician-diagnosed asthma and more asthma symptoms. So if you can look at this column, once they were in the second to fourth quartile of a poor diet, their risk of asthma was increased. And this was true even after adjusting for Hispanic background. So in all subgroups, we saw these detrimental effects of a poor diet. In fact, we went further than that, and we look at this dietary inflammatory index in relationship to measure lung function in these Hispanic adults. And as the dietary inflammatory index increased, their FEV1 and their FVC decreased. This was particularly true in those without asthma, but I think that's simply a byproduct of the fact that we had more controls than asthmatics in this study, but it was true in all participants. So far, we just recently published a perspective on this. There is an overwhelming body of evidence that suggests that dietary patterns, such as a Mediterranean diet full of with a higher consumption of fruits and vegetables, lower consumption of saturated and trans fats, when you couple that with saturated fats, good fats, if you will, like olive oil, have beneficial effects on asthma symptoms, asthma morbidity. This is true in children and in studies of adults as well. A healthy diet and exercise are in any event advisable for our patients with asthma, including Hispanics with asthma, because they help us also reduce the risk or diminish the risk of obesity and overweight, which is a major risk factor for asthma or worse asthma outcomes. So briefly talking about improving asthma care, switching gears again. So these are data from Costa Rica. Costa Rica has had universal health care since 1948, when President Figueres took over. These are data in kids and adults. My friend Manuel Soto Quiroz in San Jose did establish something called the National Asthma Campaign. This was for children and adults. And the purpose of this campaign was to get primary care physicians, internists, GPs, and pediatricians to prescribe more inhaled corticosteroids. It's an ecological study, but shown here is that after this campaign was implemented in the years following, it was done 2002, 2003, and if you can look at this, hospitalizations for asthma substantially were reduced. So inhaled corticosteroids remain, a cornerstone or mainstay of treatment for asthma, right? These are the latest guidelines for the management of asthma. These are subjects who are 12 and older. So these are adolescents and adults. And it's a stepwise approach to treatment. A major change in emphasis is before we would say to patients with mild asthma, just take albuterol or a short-acting bronchodilator PRN. Now this has shifted to when that occurs, when they have increased symptoms, use not only the bronchodilator, but also an inhaled corticosteroid. So you see that that's a major change in this stepwise recommendation. As the steps or severity of asthma gets worse, then treatment becomes sort of standing, meaning they should use this on a daily basis, right? And there are different combinations. You can increase the dose of inhaled steroids and a long-acting beta-2 agonist. These are data to emphasize this point from a very recent paper that I highly recommend you read since you're interested in asthma in Hispanics. These are data from my colleague, Elliot Israel in Boston and Juan Carlos Cardet, was published in the New England Journal of Medicine, study funded by PCORI. I was in the advisory board for this trial. And the trial was called PREPARE, stands for Person Empowered Asthma Relief. It was a randomized, open label, pragmatic clinical trial. There were 1,201 Black and Latinx adults. They all had moderate to severe persistent asthma. And the intervention, Disparities, was in essence, if they had symptoms, increased symptoms, they were to use the rescue inhaler, 1 puff of QVAR, that's what they use, 1 puff of the rescue inhaler, albuterol, and 5 puffs of QVAR. And what they found was, again, there were 603 non-Hispanic Blacks, 598 Hispanics. There were instructions given at baseline, and there were 50 months of follow-up. And the rate of severe asthma exacerbations using these symptom-triggered use of steroids and the reliever were reduced in the intervention group compared to the usual care group. And this was significant. So briefly touching on severe asthma. So what is severe asthma? Severe asthma that requires treatment with high dose inhaled corticosteroids plus a second controller, whatever that may be, leukotriene inhibitors and others. Or that requires systemic corticosteroids like oral prednisone in adults to prevent the asthma from becoming uncontrolled. Severe asthma is also asthma that remains uncontrolled despite adequate therapy. When you define severe asthma this way, it's a minority really of adults with that's about 10%. Severe asthma must be differentiated from something that is far more common, where you treat children or adults, which is difficult to treat asthma, right? And to exclude difficult to treat asthma, one must rule out alternative diagnosis, vocal cord dysfunction in adults, upper airway obstruction, CHF, COPD. Poor adherence, I cannot overemphasize this. Data over the last 5 years has shown that even in very well-designed, very well-controlled trials, adherence has not been good, whether you look at children or adults. So education is very important. And of course, comorbidities and looking at factors that may make asthma worse, right? Obesity, I have mentioned this several times. I didn't show our data, but obesity is a very well-established risk factor for worse asthma outcomes in children and adults. And looking at triggers, right? Are they smoking in the home? Is there a smoker in the home? Are there stressors going on? Is there a mental illness that could be contributing to worse asthma outcomes? But like asthma, severe asthma, we're recognizing is sort of a bucket, right? It's a heterogeneous syndrome that comprises different phenotypes and endotypes. The two endotypes that we're very interested in now are simply Th2 high or non-atopic, non-atopic mechanisms, and Th2 higher asthma, which is, again, airway eosinophilia, Th2 high. Just to guide you to this resource so that you know it's there. This is a very recent paper by two of my colleagues and collaborators, Guy Brussel and Gerard Koppelman from Europe. It's an outstanding review on use of biologics. They review the use of biologics in children and adults. I highly advise you, if you have a patient with severe persistent asthma in whom you're thinking about biologics, it's time to refer them to a specialist. Here we have a difficult to treat asthma clinic where it's an allergist or a pulmonologist. And now we have a wealth of resources. I don't think that these are for everybody, but for an adult with severe persistent asthma in whom we get some biomarkers, and here one of the most commonly used is eosinophils in peripheral blood. These biologics in selected patients have a pretty good effects on reducing severe exacerbations, which are a major cause of morbidity and cost. So I will briefly end, because we're running out of time, with root causes of disparities. And it's just to show you from a policy viewpoint, which is something I'm very interested in. Everybody, when you think about disparities, you think about health insurance, but that's the end of the tail. The reason you see these disparities in asthma or respiratory diseases is really environment. And these are the major risk factors, tobacco smoke, pollution, occupational hazards in adults, infectious agents, obesity. So why are Hispanics or Latinos, say Puerto Ricans, more exposed to that? They are more exposed to that because of structural and social determinants of health. So if a Puerto Rican or a Black patient lives in a red line district, they are more exposed to pollutants. This is true even 90 years after redlining started in the 1930s. So the time to intervene is here, preventing exposure. Once an individual is exposure and susceptible, there is risk and you can still do a screening. But then you get to establish disease, and by that time, I would say for disparities, it's a little bit too late. We should have intervened here. So again, everybody looks at the symptoms, the weed, but you have to look at the roots. And in my view, one of the main things that has to be done from a policy viewpoint is to try to achieve environmental justice, which would have a big impact on disparities in asthma and other respiratory conditions. I am not denying the importance of universal health care. I advocate for it like many of you do. This is very, very important, and we should expand it, but we should add on multiple levels. And that's why, at the ATS, during my time as president, this is what we advocate: environmental justice, access to care, and research. So in summary, asthma is a major public health problem in Hispanics with marked variability across subgroups. The Hispanic paradox is fascinating and likely multifactorial. It includes various behavioral environmental factors, tobacco use, diet, stressors. Asthma management includes addressing environmental lifestyle triggers and comorbidities. Barriers to care must be addressed. I didn't touch on this deeply, but things like cultural literacy, language barriers, transportation, and others are important. And health disparities are best addressed using a multi-level approach involving many key stakeholders. So I'd like to briefly thank my collaborators and remind you all of the golden rule, which really guides all of our work. Thank you. To stop sharing.
Doctor, thank you so much. And again, thank you for your final comment. Like you, I've dedicated my life to caring for anyone. And I think as Latinos, we should be at the forefront. And again, thank you for those comments. Que yo tenga el espíritu de mi madre dentro de mi corazón siempre para siempre. Es una raza, ¿verdad?
Así es.
So I have a question. I spent most of my career in Washington Heights and Gun Hill Road in the Boogie Down Bronx. A vast majority of my patients were Dominicano or Neo-Dominicano. So again, very racially mixed as are Puerto Ricanos. So why are we seeing this difference? Is it linkage disequilibrium or is it founder effect? I see you smiling. Go ahead.
I think, in part, it has to do, I think it's still environment, so I'll tell you, there's something fascinating, Dr. Johansson. I don't know if you're familiar with this. One of my favorite studies from the 1990s, they studied children and adults living in some housing projects in New York. And the people living in the projects were Puerto Rican and Dominican. So living side by side, same environmental exposures. They assessed, the risk of asthma, all these things, and Puerto Ricans have much more asthma than Dominicans. I think they diverge in very important aspects, besides race and mutation, all these things. So in general, Puerto Ricans, for better or worse, have been part of the US since 1898. So their degree of acculturation is far greater than that of Dominicans. Absolutely. Their diet is different. Their structural support, social support, community support, all of these things are different. So we're just delving into the surface, but I think that that's a big part of it.
Hey, and if I may, I have a second question.
Sure.
When I was training, we were dealing with the phenomenon known as Cutophysic Asthma. And as you know, there was difficulty. The part of the definition was dealing with the doctors. It was distrust, but it was also, they had the silent chest as well as lack of response to albuterol. So what are your thoughts on that?
Sure. I think part of that, there's another thing that I didn't mention, Dr. Johansson, in the chart, in the talk, but that is important. Perception of dyspnea in these Hispanic subgroups is lower. That's very important for the audience to know. So it's been shown in studies in Puerto Ricans, for instance, that for a given FEV1, right? So a white patient and a Puerto Rican patient have an FEV1 of 60%. Whereas the white patient, may feel very asphyxiated and seek care, the Puerto Rican patient may not have the same perception. So often, unfortunately, when they go to see you or go to the ED, it's pretty late, right? So I did train in the Bronx, I saw my share of status asthmaticus, right, like you did. These people coming very, very late, not using their controllers, right? We're just giving the systemic steroids, in the ED. And the other thing that I didn't mention, but that you are also very familiar with, and this is one thing that is common across subgroups. Hispanics are very reluctant to use inhaled steroids. This is being shown regardless of insurance status. So if you look at data from Kaiser Permanente, for instance, people who are in HMO, they are less likely. They get the inhaled steroid prescribed, but they are very afraid of side effects. So whether it's a mother who doesn't give the inhaled steroid to her child or an adult who doesn't, want to use it, it's a battle that we have to fight, early on in terms of education, right? So.
And I would agree, as an intensivist, I'm one of these people who like to explain all the meds and what I'm doing for the patient. And parents will now look up and they go, oh, that's a steroid. Look, I don't want that. And meanwhile, I'm of the belief the best way to intubate an asthmatic is not to. So I have tons of questions. So just tell me, Gaite, when you're finished. Where do you feel that these long-acting beta agonists with steroid combinations, such as Advair, play a role now with a lot of the biologic agents that we're seeing?
So I think it's a great question, right? So this is a rapidly evolving area. I just showed you this was published like a month ago, but I think where the field is going, and I think this is true in children and adults, right, is to, for a substantial proportion of patients, those who, up to the moderate range, to tend to use these on an as-needed basis more than permanently, right? And that goes back to this fear of steroids. So if you look at that Paradoxical trial, in the New England Journal of Medicine, right, in these Hispanic adults, most of whom were poor, the strategy of them, increasing dose of steroids along with that worked relatively well. There are also similar trends in children, I'm sure you're familiar with. There are data showing that we know that their asthma gets worse when they go back to school, right? So in fact, the joke among pediatricians, as you know, is that asthma got cured by COVID, right? and the reason was they were all using masks, they were not going to school, right? And they were not getting rhinoviruses, RSV. And in our institution, we saw a 67% decrease in asthma exacerbations, big decrease, right? Because they are not getting viral exacerbations. So some people are postulating, and it's based on data, that the best time to put them back on the steroids, right, is right before going back to school. So I think what we're going to see more and more is this this approach of using combined steroids plus the long-acting beta-2 agonists as soon as they feel, their asthma is getting worse, or if the physician thinks their asthma is getting worse, or in the case of kids, before we know they are going to get worse, right? Which is back to school time. So,
okay, we have some questions from our audience. Why wouldn't we want to address disparities after asthma diagnosis? Isn't equal access to care and treatments that is culturally appropriate also important to address health disparities?
I completely agree. What I'm trying to, there is an epidemiologist, public health practitioner in me, in addition to a researcher and a practicing physician, right? What I'm saying is, yes, we need to, absolutely, I'm an advocate of universal healthcare and will be until I pass. But you have to recognize that air pollution accounts for millions of cases of asthma, that adults with asthma and COPD have been shown to die more often, go to the hospital and go to the ED when pollution is highest. So it is incumbent on us as physicians and advocates for our patients to advocate for clean air. You know, as we all know right now in this country, there are movements or currents, right, that want to deregulate environment, you know, that leads to worse pollution, climate change. There are people into, you know, pushing vaping, e-cigarettes. There are now 22% of high school students in the US use vape.
Yeah.
And vaping is associated with more tobacco smoking. It's a new strategy to hook people on cigarettes. So we have to look at everything, you know, from the risk factor perspective to the end of the spectrum, which is healthcare. So I never meant to say that I don't advocate for healthcare. I think it's very important, but we have to start even earlier than that. That's the point.
Yeah, well, you and I share politics then. We have another question. You mentioned higher asthma prevalence in Puerto Ricans with higher African ancestry compared with Mexicans with lower African ancestry. Do you think such higher asthma prevalence in PR is due to SES or genetics?
Again, I think a lot of this environment. So I will overemphasize this because, you know, if you look, let me go back to Africa, right? So we have data from Africa. So if you go to Africa, there are these worldwide studies. What you see in Africa is if you go to rural areas in Africa, the prevalence of asthma is very low, okay? And if you go to Lagos, Nigeria, right, a pretty large city, the prevalence of asthma is much higher. So I don't think there is anything, you know, cross-African ancestry per se, but if you think about the history of African Americans or Puerto Ricans in this nation, there were, you know, this African ancestry because of slavery, let's face it. And these people have been discriminated now for multiple generations. I mentioned there are two recent papers, one which is published this month. I encourage you to look at it by Wenzel's group, showing that in the city of Pittsburgh, if you look at districts that were redlining in the 1930s, those people living there are still exposed, you know, to higher levels of particulate matter, ozone, you know, so I think that's what's going on. I don't think that, you know, it's that Puerto Ricans are racially inferior or the Africans. I don't think that's the case.
But I agree with you. You know, we need to be more cognizant of social determinants of health. You know, having grown up in the Bronx, and you know, my nickname was Güerito, despite my family's Tragañitos. And again, that's obviously a genetic mix. Yet I got out, but all my cousins have asthma. I don't. So was very excited to hear this about how the chromosome 17. Any other questions? Oh, excellent. So we do have some upcoming events that I'd like to bring everybody into tune with. That we have COVID virtual 19 series briefings. We've been doing this. This is actually number 18 now. And if you haven't gone to any, now it's more important than ever to get involved and listen to what people are talking about, more than just, is this going to be like flu? Because as an influenzologist and published a great deal on flu, I resent just like flu. Flu's a killer, and so is COVID. We're also having our conference in Chicago. I'd invite everyone to come. It's a wonderful conference and opportunity to network. And we're continuing our NMHA Vaccinate for All campaign. I'd also like to add, we're doing All of Us, which is a research effort. And I've always been a little put out anytime I get a grant to review or a paper to review, and they just say Hispanics. And again, Doctor, I was so glad you see that you put up that we are racially diverse, even though I don't like the word race because I think racism created the word race. But we are, my grandmother would say, we're sofrito. We're a mixture of many wonderful things to make this incredible spice. Good, another Latino, Caribbean Latino. So anybody have any final questions? Well, I would like to thank Dr. Celedon. I thoroughly enjoyed your talk today, and it really brought a lot of things together with my own research and practice. So I cannot tell you thank you enough for doing that. I'd also thank all our other guests for participating today. And again, I really want to stress the thanks from Amgen for supporting this event. There have been some questions in the chat. Yes, the recording of today's discussions will be added to our NMHA YouTube. And I hope everyone enjoyed the webinar today as much as I did. And please join us for upcoming events. And if you haven't joined NMHA, please do. We need more advocacy. We need our voices heard for getting what we need for our people and for what we need to get done to help our people. And again, Doctor, muchas
Thank you
gracias.
so much, Dr. Johansson. It's a pleasure to meet you. Thanks for everybody for attending. Muchísimas gracias. Que Dios los bendiga. Y que
Vaya
tengan
con Dios.
Bye.
Ay, gracias, un Dios.